Welcome, everyone. I am Rachel Kimbrough. I am an assistant professor here in the Sociology Department and a Rice Scholar here at the Baker Institute. As director of the Urban Health Program at the Kinder Institute for Urban Research, and on behalf of the Health Policy Forum at the Baker Institute for Public Policy, welcome to our official launch event for the Urban Health Program here at Rice. It's our hope that this new program can serve as a central community for health disparities research and education in Houston, as well as an organization which focuses on bringing together academics, practitioners, public servants, healthcare workers, and students. We're so glad to see so many colleagues here from different institutions around Houston. If you would like to sign up for our program newsletter, there'll be an opportunity for you to do that after the talk during the reception. I wanted to quickly thank a few people who've been instrumental in organizing this event, including our two program assistants, Sarita Panchang and Gabby Rodriguez, as well as Anthony Potachniak and Megan Dillingham at the Kinder Institute, as well as the wonderful staff here at the Baker Institute, especially Melissa Llewellyn. And thank you to the Health Policy Forum for hosting us here at Baker, and the Kinder Institute for Urban Research, which is directed by my two colleagues, Michael Emerson and Steve Kleinberg, for sponsoring this event. We are delighted to have a distinguished panel here tonight to speak about the social determinants of health, with a focus on how all social policy is health policy. In other words, how policies which support education, neighborhood renewal, work, and earnings for low-income Americans also directly impact public health. This is a topic that has particular resonance today, as there is a new national dialogue around issues of inequality, and our presidential candidates and President Obama are engaging these issues in their political rhetoric every day. Before I introduce our speaker, Dr. Woolf, I wanted to introduce the Associate Director of the Urban Health Program, Dr. Justin Denny, also an Assistant Professor in Sociology. Serving as distinguished panelists tonight are Dr. Mark Hayward and Dr. Vivian Ho. Dr. Hayward is Professor of Sociology and Director of the Population Research Center at UT Austin, and his research focuses on the social determinants of health across the life course. Dr. Ho is the James A. Baker III Institute Chair in Health Economics. She's also a Professor of Economics here at Rice, and a Professor in the Department of Medicine at Baylor College of Medicine. Her research examines the effects of economic incentives and regulations on the quality and costs of healthcare. Our speaker tonight is Dr. Stephen Woolf, Director of the Center for Human Needs and Professor of Family Medicine at Virginia Commonwealth University. Dr. Woolf is the author of over 120 articles. He is a scientific advisor and member of the U.S. Preventive Services Task Force, and has also been a member of the Institute of Medicine, as well as the National Academy of Sciences since 2001. His research focuses on health disparities and the social determinants of health. Dr. Woolf has recently published several influential articles which make the case for social policy as health policy. Tonight, please help me welcome him to the Rice campus.
Thank you. Good evening. Pleasure to be here. It would help me actually if you could just let me know whether you're in the healthcare field yourself. How many of you are connected with healthcare? Okay, that helps to know. I'm a physician myself, and I come to this from that perspective. And what I'd like to talk with you about over the next few minutes is really just a framing discussion. Not going to get too heavy into the research, some data that I'll present, but really more about how we think about the determinants of health and what influences healthcare. So let me see if I can get the slides to advance. There we go. So those of us who are from clinical backgrounds, and frankly, much of the public and many policymakers operate under the assumption that health is determined by health care. So when we think about cardiovascular disease, cancer, stroke, diabetes, the expectation is that if we're going to do battle against those diseases, the battle takes place in hospital settings, doctors' offices, through medication, treatment, surgical procedures, biomedical advances, and so forth. But a growing body of research has documented that a large proportion of the diseases, especially the chronic diseases that are the major health challenge of our time, are products of health behaviors like tobacco use, diet, physical inactivity, alcohol use. The CDC estimates that about 40% of all deaths in the United States are attributable to those four health behaviors: tobacco, diet, physical activity, and alcohol. So medical care is important. It certainly is the case that once you've developed disease and are in need of clinical attention, medical care is important. But many of the upstream factors that are responsible for the diseases are influenced by behavior. Now, what I'm showing you right now is a schematic that was developed by the Robert Wood Johnson Foundation Commission to Build a Healthier America, which released its work just a few years ago, and was a blue ribbon panel of distinguished experts who tried to draw attention to the importance of broader determinants of health. And one of the things they emphasized was not only that health is determined by more than healthcare and personal health behaviors, but those in turn are shaped very much by living and working conditions, the conditions where we live, where we work, where we go to school, where we play, where we age. Our environment, both the neighborhood environment, community environments, are very instrumental in determining what health behaviors we pursue and, frankly, our ability to access health care. And those, in turn, are shaped by larger macro policies that are responsible for the nature of those conditions in which we live, work, and play. So social and economic opportunities and resources shaped very much by public policies made by government and the private sector are all part of the big picture of what's driving health. Now, this is the schematic that they developed. It's really based on older work. This is the Socioecological Model that was popularized some years ago, reprinted here in a 2003 report from the Institute of Medicine. And the basic idea here, the font is probably too small for you to read, but somewhere in there, let's see if my laser pointer is working. I guess not. In the central circle there is showing you major inherent drivers of health, such as your age, your gender, your genetic composition, and so forth. That, in turn, is influenced by individual behavior, and as those concentric circles widen out, you can see the role of social, family, community conditions, living and working conditions, and so forth. So this notion that our health is the product of more than healthcare has been around for some time. And it's very much colored our understanding of what's going on when we think about health inequalities or health disparities in this country and in other countries. You don't need to be able to read the fine print here, but this is a map of the United States at the county level showing you age-adjusted mortality rates for whites and African Americans. The whites are the upper maps and the African Americans are the lower maps, and all you need to know is that the darker the shade, the higher the mortality rates, reflecting the large disparities in mortality. This was a metro map that was developed by the RWJ Commission to Build a Healthier America, a subway map for Washington, D.C., showing life expectancy at different stops. And part of what is going to be a theme through the comments I'm going to make over the next few minutes is efforts that are being made to try to present this concept of social determinants of health in ways that are engaging to the public and to policymakers. This was one such attempt to try to help people come to terms with what this really means. A study that Chris Murray published some years ago called the AAT Americas divided up the U.S. population into 8, some would say, arbitrary categories based on different racial, ethnic, and geographic characteristics. But I guess the important point here is the huge disparity in life expectancy between different population groups. The life expectancy difference between Asians in the top row and urban, high-risk African Americans in the bottom row is quite striking. Now, this is a very simple schematic, but I think it's worth taking a minute to explain what's going on here. So many of you have heard of primary, secondary, and tertiary prevention. I don't know how many students are here that have studied this, but just for purposes of refreshing your memory, primary prevention refers to the attempt to prevent the occurrence of disease in asymptomatic people. So in other words, somebody who has not yet developed disease, encouraging them to eat a healthy diet, be physically active, stop smoking, so that they don't get the disease in the first place. Secondary prevention is an attempt, also in asymptomatic people, to identify disease in its early stages. Cancer screening is a good example of this, where you're trying to identify somebody who has not yet developed symptoms of colon cancer or breast cancer, et cetera, and you're identifying it in its preclinical stages. Tertiary prevention is everything else. It's the effort to try to prevent complications of disease after people have become symptomatic. So we spend $2 trillion a year on healthcare in the United States. We all are familiar with this problem, the huge percentage of our GDP. Which part of this diagram do you think that sits in? It's this tertiary prevention category. Really, much of what we do in medicine falls into that category. The only things I can think of that are exceptions to that are palliative care and such efforts. Most of what doctors do and what hospitals are busy doing is trying to take people who are already sick and prevent further complications. The point of this diagram, it's a very simplified schematic, is to show the relative importance these categories of care have on health outcomes. And the point here is that primary and secondary prevention are far more influential on determining health outcomes than much of what we do in medicine. But over there on the far left-hand side is social determinants of health, which I will argue in this talk competes with primary and secondary prevention, and in a way is part of primary and secondary prevention. It has tremendous impact on health outcomes. This is a conceptual model that was published by the World Health Organization, which also had a commission on social determinants of health, a very important effort in Europe to try to review all of the evidence on the topic. And all I want to focus your attention on here, this is another diagram showing the multiple layers of influences on health. And I don't know what I'm doing wrong with my laser pointer, but is to show you right here the health system. Can you see this? The little box there? That's where it fits into the big picture. So those of us who work in medicine and in healthcare tend to have a somewhat narcissistic view of our influence on health outcomes, but it's really part of a much bigger picture of factors that drives health outcomes. So how many of you are physicians and nurses? Okay, so you'll relate to this. When I was in medical school, Steve, you'll remember this, this would be a typical form that you would fill out, a history and physical form when you admitted a patient to the hospital. And it would have the history of present illness, the chief complaint, family history, review of systems, and so forth. And right up there in that upper corner there, my pointer's not working, but it's about 4 lines down on the right, it says social. And that was this little space where you were supposed to write in something about their social background. And usually that left enough room for you to say positive tobacco or negative tobacco. That was about all that would go there. But really the intent in having that on there was at least a recognition that this matters to health. Social determinants of health that I will be discussing in the next few minutes clearly are important in day-to-day medical care in helping to understand what factors enable patients, for example, to adhere to medication regimens, the barriers they face at home in getting access to care, affording prescription medications, understanding instructions, discharge instructions from the hospital, and so forth. And during the discussion period, we can talk more about that. But I want to back up a little bit on that causal model and talk about other determinants of health that operate at a population level that are equally and perhaps more important. First, I'll talk about downstream determinants. What I mean by upstream and downstream determinants is that there are, in those conceptual models that I was showing you earlier, I'll back up for a second and remind you. Over on the far right-hand side, you've got health outcomes. The determinants that impact immediately on those health outcomes are thought of as downstream or proximate health determinants that directly impact those health outcomes. And then there are these other factors to the left that feed into those, which are more upstream determinants that affect the prevalence of the downstream determinants. I'll explain this more in a second. So for example, diet and physical activity, tobacco use, we talked about the importance of these health behaviors in driving health outcomes, are very much determined by conditions in the environment that make it possible for people to adopt a healthy diet. So you can, as a doctor, say to your patient, you should eat fresh fruits and vegetables, 4 or 5 servings a day. You should limit your intake of calorie-rich foods, avoid fast foods. But what if the person doesn't live in an environment where there's access to healthy foods? Tobacco and alcohol use are very much affected by advertising and other environmental factors. Healthy housing, safe neighborhoods affect risks for violent injury and other consequences of crime, and so forth. Our environment is very much an important factor in driving health outcomes. But these, in turn, are driven by upstream factors. Education, income, employment, and a number of other variables that we'll talk more about in a few minutes very much influence the degree to which people are exposed to unhealthy environmental conditions, their ability to escape unhealthy environmental conditions, and more broadly are affecting how neighborhoods and communities are able to invest resources to make living conditions more healthy for local citizens. So this is a familiar list that people are aware of the leading causes of death in the United States, showing that tobacco and diet and physical activity, obesity, alcohol, and so forth are major causes of illness. And this has really changed the job for the healthcare profession, because there's a epidemic, a growing prevalence of chronic disease in this country, especially with the aging of the population. And 75% of chronic diseases are attributable to these health behaviors. So whereas traditional clinical interventions like a surgical procedure or other interventions that really can be done in the doctor's office or in the hospital for the most part, where most of the work takes place there, in contrast, dealing with these health behaviors is something that the clinical sector can only marginally impact. So we are being driven increasingly to think beyond the clinical setting in terms of understanding how to address these health behaviors. So if you're a pediatrician and you're doing your job and you're telling the parent, make sure Johnny gets plenty of exercise and goes outside and plays every day, but Johnny lives here, your advice isn't going to be very useful. And you're not going to be very useful unless you understand where Johnny lives. So that's important for the clinician to be conscious of the living conditions affecting their patient, but it's also important for the public health community to think about what do we need to do to really make a meaningful change in the prevalence of unhealthy behaviors. Food deserts, areas of urban centers where people do not have access to a supermarket, a farmer's market, or another resource for buying fresh fruits and vegetables. It doesn't matter how committed the parents are to serving a healthy diet to their family. There's a whole controversy. We can also talk about personal responsibility, the notion that these health behaviors are up to a person to decide whether they eat a healthy diet or light up a cigarette or are sedentary. But these environmental factors become barriers for people who do want to make the right choice and pursue healthier behaviors. So this has led to a movement called the Health in All Policies movement, a growing recognition that health is determined by policies that we don't normally think of as health care policies, but are very important to health. So if we talk about where the supermarket's located and think of that as a decision by a zoning commission, that's not a typical healthcare sector issue. Tax incentives to encourage the supermarkets to move there. Environmental policies that decide whether bus depots should be located near residential neighborhoods where there's a large community of color. Transportation department decisions about where to put pedestrian walkways so people can walk or cycle to work or school rather than drive their cars. Increasingly, we're recognizing at the federal level, state level, local level that agencies that are not in the health department are very relevant to health outcomes. I wanted to share with you very briefly a few efforts we've made to try to put this in perspective, because I think the public generally understands that education and income have some importance to health, but because of this pervasive view that health care is really where it's at in terms of battling disease, there's not a recognition of how big a deal this actually is. So we've undertaken several thought experiments, is what we call them, to try to help put this in perspective for people. This one was our first, where we basically looked at the disparity in mortality by race. And what we did, I won't drag you through the scientific details unless you're interested. So we tried to calculate for the decade of the 1990s how many deaths were averted in the United States because of biomedical advances. So we tend to believe that those are important to saving lives, and we made this very conservative assumption in this study that the gradual reduction in age-adjusted mortality that occurred in the United States during the 1990s was entirely due to medical advances. So year by year, death rates in this country fall by about 1%. We pretended that during the 1990s, that entire reduction in death rates in the United States was entirely due to biomedical advances. We all know that's not the case. Other factors were in play there, but just for the purposes of this exercise, we calculated that altogether over the 1990s saved 176,633 deaths in the United States. Then we said, for that same time period, what if we waved a magic wand and erased the difference in mortality between African Americans and whites? And what we determined was that 886,000 lives would be saved. That's a ratio of 5 to 1. So to summarize that, what we basically showed is that for every life saved in the United States through biomedical advances, 5 would have been saved if that disparity in mortality didn't exist. Well, there aren't magic wands, and there's a reason why the disparity exists. The social determinants that we've talked about are very important. So we next turned to education. And we did a similar kind of thought experiment where we asked what would happen if we eliminated the disparity in mortality that exists between people at different levels of educational attainment. This was done for the years 1996 through 2002. The large maroon bars in the back are the number of lives saved if all adults in the United States had the mortality rate of people who attend some college. And the shorter bars in the front are the number of lives saved by biomedical advances. So again, what you're seeing here is just a sense of perspective. Again, there are no magic wands, but to help the public and the policymakers understand that education, something that it seems like it belongs to a different committee, a different jurisdiction than health, is actually a major driver of health. One of my colleagues, Jonathan Fielding, who's the Commissioner of Public Health in Los Angeles, is fond of saying that if modern medicine wanted to do one thing to save lives, it would be to deal with the high school dropout problem. So health policy really has answers in social policy. Education reform, helping with college graduation, college attendance, and so forth are not issues that are irrelevant to the health professions. I'm from Virginia. We did this study where we took advantage of an interesting situation that we have in our state where there are areas right outside of Washington, D.C. that are among the most affluent counties in the country. Median household incomes are very high in those counties. But in other parts of the state, there's severe poverty in the coal fields and other areas of the state. And we did one of our thought experiments. We said, what if we took the mortality rate right outside Washington, D.C. in those affluent counties and gave it to the whole state? And what we showed is from 1990 through 2006, basically 25% of all deaths would not have occurred if everyone in the state had the mortality rate of those affluent counties. And we mapped it by county and showed, as expected, very large proportions of deaths that would be averted in areas of high poverty. So why does all this matter now? Well, I'll point out 4 reasons. One, the economy. If you believe what I've just presented, that the socioeconomic conditions matter to health, it's a problem that we're going through a period right now where most of the American population is experiencing severe economic stress and problems with socioeconomic opportunities. So if you think those matter to health, then it's a safe prediction that a wave of adverse health outcomes is coming our way as a result of the current conditions. Secondly, children are being exposed to this. So if you believe in the life course perspective, that means that there is a cohort of Americans that are now growing up under these conditions who will later be adults with more severe chronic diseases and other difficulties as a result of this exposure. Third, the safety net, which is there to help buffer the impact of some of these conditions on health outcomes, is being taken away because of budget stresses and political decisions, therefore heightening exposure of the population to these conditions. And an election is coming, as was just mentioned in the introduction, where many of these issues are being debated. And it's important for people to draw the connections between some of these policy issues, like what do we do about jobs, and what do we do about income and prosperity in America as one issue over here, and then this other issue over here, the healthcare crisis, and how much money we're spending on healthcare, and understand that these are interconnected. I want to skip ahead in the interest of time to show you this study, which was published by Bobby Milstein and colleagues from the CDC, where they looked at 3 different strategies we can take with healthcare. The one is the one that we've just gone through with the healthcare reform, which is focusing on dealing with the uninsured. The second is trying to improve the quality of the healthcare. And the third is what I just talked about, dealing with these problems outside the clinical setting that are driving illness. And what they showed is it's the third, especially if you look out over a 25-year window, that saves the most lives. This tall bar here that's over to the right is showing you the number of lives saved. And the turquoise bar, I'm not good with colors, is costs. And you can see that costs are actually lowered. It's the only category of policy intervention that actually lowers costs. Or another way to visualize it, which I think is more effective, is this chart that they developed showing what happens if you layer these interventions. So the only one, I'll just cut to the chase, the only one that really bends the cost curve, the green one, the only strategy that actually starts lowering costs on healthcare over time is the interventions outside of healthcare to reduce the flow of disease into the system. We have tried various ways to try to make this understandable to the general public. One tool that we've developed is called the County Health Calculator. How much time is left? 5 minutes. Okay, I'll squeeze this in. So 2 examples I'll show you, one from Ohio, one from New York City. Over there in Ohio are 2 adjacent counties, Knox County and Delaware County. I don't know if any of you are from Ohio. This is right near Columbus. Are you familiar with these counties? One's doing pretty well and one's not doing quite so well. And this tool that we developed basically looks at the relationship, helps people sort of understand the relationship between education, income, and mortality. Shown here is Knox County is the county that's having issues. 41% of adults in Knox County have some college education. And if you look down below that, you'll see that the best county in the state is that county next door, Delaware County, where 75% of adults have some college education. What you do with this slider is you slide the slider anywhere you want to see what effect what the effect on mortality in that county would be if education levels were different. So for the purposes of illustration here, the slider has been moved up to 75%, the value of the neighboring county, Delaware County. And what you see if you look at the very bottom row of the slide is that 32% of all deaths in Knox County would not have occurred if they had the mortality rate that would exist with the level of education in the neighboring county. The other example is in the Bronx, New York, and this time we're looking at income. In the Bronx, 49% of adults have what we call a basic income, which is an income above twice the poverty level. And let's say you live in the Bronx and you want to know, well, what would happen if we had the income level of Queens? The income level is 69% of adults in Queens have a basic income. You slide the slider over to 69% and you look down at the bottom row and you see that roughly 10% of deaths in the Bronx would be avoided by doing that. Raise the slider up to 86%, which is the income level in Long Island, and you're up to 17%. So I want to wrap up so that we have time for our other speakers, but just simply to summarize by saying that what all of this tells us is, I mean, we can talk during the Q&A about how the limitations of this kind of data in terms of inferring causality and the confounding variables and so forth. But the important takeaway is that policies that are outside the healthcare sector are not only relevant to health, they may be more relevant to health than where all the attention is currently being focused within healthcare. And thank you for your time.
Okay, thank you very much, Dr. Woolf. We want to keep this going. We have a couple of wonderful panelists with us here today that we're going to ask them to make some brief comments and reactions to some of the things that Dr. Woolf has brought up here today. So we're going to start with Mark Hayward. And Mark, I know you have a few slides you'd like to show as well, and those should be queued up here.
I don't want to be redundant with what Stephen's saying, but I will be partially redundant, but I will also say that social policy is becoming more important so fast that we probably can't even imagine how fast the changes are coming. So I'm going to put some of what Stephen says in a larger historical context, and I'm going to focus on some work that my research team, Bob Hummer, myself, colleagues, have been doing at the University of Texas to put Stephen's comments in a little bit broader historical context going back to 1960. And we're going to focus on one of those FAR variables that Stephen talked about, education. And in fact, our group thinks about education as the master variable in a lot of this discussion, and certainly it's one of the most policy manipulable variables that you can imagine. So if you want to think about this relationship between education and mortality, I've given you the kinds of ways in which education may have multiplier effects in terms of affecting health in a variety of ways. There's the classic ways that many social scientists think about in terms of jobs and associated rewards, and I want to put this in the context of an information-based society. There's the valued information about and support for healthy lifestyles and healthcare that comes with more education. More education may provide you with access to valuable networks and relationships, and perhaps increasingly so with technology advancements. And of course, we don't want to forget about more sophisticated cognitive skills, greater sense of control, and human agency that goes along with education. Now, every once in a while, I'm on an airplane and people say, "What do you do?" And I say, well, I'm actually engaged in this long-term study funded by the National Institutes of Health to look at this relationship between education and mortality. And they go, oh, there's a relationship between those variables? Well, part of the problem may be coming back from probably one of the most important studies that was ever done in the United States that launched 1,000 ships. And I'm sorry that my slides are a little off. They used to be lined up. But this is the first study that looked at educational differences in adult mortality, and it's centering right on 1960. And one of the things to observe is that, and don't pay attention so much at the numbers, but the mortality rates for people with 0 to 4, 5 to 7, 8 years, 1 to 3 years of high school, 4 years, and so on into college, until you get to college in 1960, there really was no effect of education. So each year of education up till the college degree didn't matter. All right? Whoa. We're very hydrated up here. In 1980, another study was done by an epidemiologist, Backlund, and some colleagues, and one of the things that is quite clear, just focus on the dotted lines, if you will. Here is the relationship between each year of education and the risk of death. And one of the things that you notice is that there really is no relationship between education and the risk of death up until you get to high school, and then it drops, and then it continues on up until college, and then it drops. And it's the same basic pattern for men and women. And this gives you this idea, if you were just to take this slide, that it's really about labor market certification and access to job rewards. Now notice, between 1960 and 1980, there was no high school effect in 1960. Everything was constant up until college. By 1980, we had seen a shift already in how education was related to mortality. What about now? We have a study being published next month. This is now. It's changed entirely then from the 1980s. I've shown you the red lines which mimic the 1980 pattern. The black lines up here are what's going on now. There is a nice gradual change, improvement, or lowering of mortality up to grade 12, a drop, like a big step function, certification. I get access to labor market related rewards if I have a high school degree. Remember Stephen's comments about if we could only get people to graduate from high school. Here's that effect shown here in terms of those mortality rates. What happens after high school? It's a race to the bottom. 13, 14, 15, 16, 17, 18, 19 years of education, there is literally a linear drop now that we have never seen before. It is so fast, and there right now in the data, there is no floor, right? The normal way we would think about it is, gosh, there should be a floor somewhere out there. We're in a world where economists would say we are not in equilibrium. What this means is that the world out there, exogenous conditions, are changing so fast. And they're changing in ways which are making, in some ways, education and advanced education especially important for what we're looking at in terms of reducing risks of mortality. The long and short of it is, education appears to be increasingly important, and I mean knowledge, in gaining control over the environment and gaining control over your body. And this is occurring at a very rapid pace. The bottom line is that wave of social policy becoming more important is a very fast-moving wave, and is likely to, that policy is going to become even more important in dealing with the population health issues now and in the future than we've seen in the past. Stopgap measures, I applaud the healthcare reform, but if you think it's going to lower healthcare costs, Stephen's shown us some evidence. If this wave is getting bigger and moving faster, it really is these policies that ultimately will help us reduce the costs. Thank you.
Thank you, Mark. Now we would like to get some comments from Dr. Vivian Ho here at the Baker Institute, and then we'll have our lovely panelists and speaker take front and center stage here, and we'll take a few questions from the audience. But first, we'd like to hear from Dr. Ho.
Right, so I'm going to wear my economist hat tonight. And from the economist perspective, I completely agree with everything that the two previous speakers have said tonight. We've actually, in the economics field, we've been quite interested in the relationship between education and health outcomes and health behaviors, say for 20 or 30 years now. And so a lot of what explains the relationship between education and better health is that more educated people have better health behaviors. And so we tried to say, well, what explains this? Because you might be thinking, is there some easy way around this? You know, did we find these results between education and health because more educated people are just, they earn more, so that's, they're able to buy better stuff. Turns out when you try and explain the gradient between education and health, the economic resources, the earnings only explain 10% of that variation. So about 10% is from there. Another thing you might think, maybe there's some easy answer to this. Let's just have a little bit better information on our public health messages, make it clear to uneducated people that smoking causes cancer. Let's just give out this public message. So economists went out and sort of looked at the survey data, and they looked at could you explain the relationship between education and health behaviors by how much people knew about how much, what types of cigarette smoking affect what types of cancers, and, how much does alcohol affect liver cirrhosis and things like that. That's another 10% of the variation. It turns out that the biggest chunk, and it's still not the majority, is actually cognitive processes. So 30% of the relationship between education and health behaviors is just more educated people can process things better in their mind, so they get the messages better in terms of, yes, now I understand exactly why smoking is going to make me worse off, and then change their behaviors and things like that. And then another good portion is actually unexplained. We can't explain it in the data. So this tells you there's no shortcut. If you really want to sort of, improve health, you're just going to have to take the whole hog approach, and it's a completely, sort of all education, getting people into school and getting them to stay in school and graduate. The second point I'd like to make is sort of, this is not just when we're talking about these particular interventions and better education and a better social safety net, it has implications beyond just healthcare. And it's basically, from an economist's perspective, it's cost effective to give children a good start in life. All right, you can actually make a business case for that, and we did that in a Baker Institute report. We actually looked at what are the costs of covering children with health insurance while they're children, and then look at the economic benefits further on. And that's in terms of health consequences and in terms of labor productivity. So you give children health insurance, they get good health care when they're young, and that actually leads to better productivity, and their earnings and resources they generate for society are much better than the cost of health insurance. Jim Heckman also, he's a Nobel Prize winner, spent his entire career looking at labor supply, and he actually is showing that we underinvest in children in disadvantaged families. Okay, so not just in healthcare, but in everything else. And what he argues is that if you had just invested in preschool programs for these disadvantaged families, you would save so much in the long run. It would be cost effective because not only are you reducing future health care, but you're actually reducing future crime, you're having better labor economic outcomes and things like that. So it's a business case. It's, so thinking from the perspective of an economist, being perfectly selfish, this is something we should do to get better returns. So then you might be thinking, this is still caring about all those, one of our candidates said, those poor people in the safety net, let's just worry about us. We're in the middle, we're the middle income class, and that's what we should be thinking about, okay? There are a substantial number of researchers who have claimed that higher income inequality leads to worse health for the entire population, okay? That it can actually lower health outcomes, average health outcomes in an entire country or an entire state. I've actually looked more closely at the research, and I don't think it plays out that way. So you may say, look, this just applies to these other folks, and I don't have to worry about me. But there's a part of economics research that I think is still missing, and this is the part I can't give you any solid economic data on. But again, thinking purely from a perfectly, sort of selfish perspective, when we talk about underinvesting in this population and they have poor education and they have poor health, what does it mean to you when you get older? And as I'm getting older, these things start to concern me. This future population is going to be our future population of firefighters, teachers, police officers, people that are going to affect us regardless of where we are on the income scale. And you start thinking, gosh, maybe it's already affected us. If you looked at what happened to sort of the DNA scandal and sort of in our police station here in Houston, you sort of think, gosh, what has happened in terms of our education status? I think just on just a personal basis, when I discover more service workers who aren't able to take my orders correctly when I request something fairly simple, okay? These are people who require education. But then I say, well, what about health care? Well, as I'm getting older, the types of preventive screening or sort of minor medical procedures I'm getting are becoming more complicated. So it's not just a question of having access to a very highly skilled doctor. Your health outcomes are going to depend on this population, this large population that we have chosen not to invest in. And I start thinking about the outcomes. I actually had to have braces recently, and I think of the technician who took the x-rays, and she did such a poor job that she had to take them over and over again, and I'm getting extra doses of radiation. So that's the type of thing when we talk about the skills of our population and what are we investing in. I think maybe you don't see something aggregate in the data in terms of average health outcomes, but there's no guarantee that any one of us in this room isn't going to be affected by this poor choice of where we're directing our resources. I'll leave it at that.
Thank you very much, Dr. O. All right, we'll ask all of our speakers now to take a seat here front and center. And we have a few minutes for at least some questions, and fire away.
We have all this knowledge and data, and then we have politics. And I didn't grow up in this country, so when I moved to this country in my 30s, I was really struck by the level of kind of propaganda in the United States that keeps people unaware, and even some well-educated people, of the implications of the data that you're presenting. And we're in a particularly difficult and challenging political cycle right now, where we keep hearing very ignorant messages about what's going to turn around the United States. What are your thoughts on that?
Well, I share your concern. It's always been an issue. You could go back 20 or 30 years or longer and talk about how the evidence or research only went so far, and then politics entered into the process. That's just the nature of how our country operates. However, I have gotten rarely disheartened recently by the total irrelevance of reality to the dialogue that's going on. So you can just completely, the expression, don't let the facts get in the way. This happens way too much now, to the point where I really wonder how much we can accomplish as researchers in moving the needle in the conversation among policymakers who really may not care so much about what the facts are as opposed to what the rhetoric needs to say or what their constituents need to say. So that's in my more dismal, cynical mornings. I'll feel that way, but other times not so much. The other thing, though, is I just want to follow on to Vivian's remarks to say that it's very important that a lot of these rhetorical messages be challenged around the facts. So one of the questions is, how much do we care about those poor, disadvantaged people? And you've made a compelling argument about why that really is relevant to the rest of the population. But what the Robert Wood Johnson Commission that I cited before documented rather extensively is a very definite gradient in health outcomes throughout the middle class. So it's not just that the most disadvantaged members of our population have worse health outcomes. The middle class has worse health outcomes than their more affluent peers. It goes all the way up that 99%. So there's people who are doing relatively well off, who have inferior health outcomes relative to the upper tier. The other point I'll make is that studies that make international comparisons between the health of Americans and the health of people in other high-income countries have shown not only that the U.S. has worse health, this is pretty well known, life expectancy is lower and so forth, but even if you adjust for socioeconomic status, you'll find that the most affluent Americans have worse health outcomes than the most affluent members of the other population. In some cases, worse health outcomes than the least affluent members of other populations, suggesting that it's not just having money or being insured that is responsible for our adverse health outcomes. There are inherent problems with our social policy and way of living in the United States that is affecting health outcomes and doesn't spare even the upper income folks.
I would like to comment on that question as well. One of the things that we forget, and I hate to bring back history, is that this idea of social policy as health policy has not really gained a lot of traction until, I'd say, post-2000. And so the kind of conversations that we have here in the United States haven't picked this up. On the other hand, Obama's messages about education right now are a good example. I think if you were following what's gone on in Europe and Davos, when they're talking about inequality issues, these kinds of inequality problems, the safety nets, and the relationship to population health, I think, are becoming part of the mainstream conversation. We may not have gone very far with the conversation in the U.S., but for the first time, we're actually having that conversation. And I think, we have to, in a larger context, it's at least there's some traction.
Another question?
You were talking about how you control for income, and even within income brackets, there's education like makes a difference. But people that attain more education tend to come from higher income backgrounds in the first place. Like, how are you able to separate where they were when they were children from where they end up?
I think you should answer that. Causality issue.
What happens is that education actually adds to what happens when you're a child. So we've been doing some new work on childhood socioeconomic disadvantage, creating a kind of I'd say an index of how resource rich the home is, and looking the extent to which education can compensate or overcome in those early childhood disadvantages. And it is quite clear that the education effects have a whopping consequence, so that if children from some disadvantaged backgrounds are high achievers and do, graduate from high school, for example, the effects on not only mortality, but on the period of life with which they spend in poor health, it's really it's amazing. So yes, there is this kind of childhood advantage that works through education. Education partly explains childhood disadvantages and advantages, but only partly. Education really it's almost like think about this as a cumulative exposure idea. You have resources in the home, you have new resources or disadvantages coming in from education, what happens in adolescence, in the workplace. So you really want to think about from this idea, does the body forget? Well, no, it really usually doesn't forget. But it has this kind of memory from these kinds of different exposure that are going through all the way from birth to death. So,
If I could add to that response, there have been economic studies that have looked at cases in our history in the U.S. where we've had increases in mandatory schooling. And what you can do is you can look at the increase in schooling that results from requiring, say, everyone to stay in school until they're 18 versus staying in school till 16, and you could look at variations across these states. And so those studies control for the type of differences in the parental background that you're talking about, because all the effect of increases in schooling is due to the mandatory schooling effects. And when you look at those studies, it's only a small part of that entire spectrum, but even in those studies you find significant increases in life expectancy resulting from these increases in mandatory schooling policy. So it's still there. It's pretty amazing.
But I'd like to ask you to elaborate on some potential solutions. Are you aware of evidence-based practices that can be adopted on the local level that have a major impact on this issue? If you were a policymaker and suddenly had the ability to do something, or a group of volunteers and had the ability to do something, or business leaders had the ability to do something, with or without funding, could you point us in the direction of, initiatives that have been successful?
Well, here's the interesting thing about it. What I'm talking about in this notion of social policy as health policy are not new interventions. It's really drawing the connecting the dots between interventions that our society is already intent on addressing. So we don't need to do research to say we should do something about the economy. The politicians are out there saying jobs, jobs, jobs. So there's no need to marshal scientific evidence to convince them that we need to do something about jobs. The message here is that actually has relevance to health outcomes. There's no shortage of people advocating for education reform, for early childhood education, for improving K through 12 education, through increasing opportunities for college education, college scholarships, and so forth. That's already going on. The problem is that the people who are advocating for education and asking for more budgetary support for that are not necessarily making the public health argument along with it. And the people who are turning them away and saying, we don't have funds for this, we need to spend the money on Medicaid and we need to spend the money on Medicare, are not drawing the connection that if we invest in education, we may end up actually reducing and bending that cost curve. So it's really about connecting the dots. A quick anecdote that I'll share with you. I published a paper in JAMA about this notion of the effect of budget cuts on health outcomes, and wanted to pass it along to people in the Senate and one of the committees at the Senate. I called up the person on the phone. I said, my name is Dr. Woolf. I want to talk to whoever handles the education desk. And she said, just a minute, I'll transfer you to our health staffer. And I said, no, don't transfer to the health staffer. But I got put on hold. I'm listening to music. I get the health staffer. Had a polite conversation with that person, hung up, called back again. And I had to blurt it out again. I decided this time not to say Dr. Woolf, because the mental jump that was being made there by that person, a doctor, health desk. Why would a doctor be interested in talking to somebody about education policy? This is the kind of connections that we need to start making.
A couple of more questions. Yeah.
How would you fit immigrants into this picture? For example, if they get high levels of education and have very nice cognitive abilities in their own country, yet they come here and they're unable to access the job at the level of education that they used to have because their degree is not honored here, or they don't get culturally and linguistically appropriate services in healthcare, where would you fit them into that picture?
Well, it's a fascinating subject. We were talking about that on the ride from the airport. It's a very complicated dynamic, and we probably don't have time to get into it all, the whole Hispanic paradox, immigrant paradox phenomenon. But to draw it back to the theme of this discussion is recognizing that the deterioration in health outcomes that occurs with second and third generation immigrants who've come to the United States has a great deal to do with the living conditions that they're experiencing. Once again, it's not all about health care. It's about the unhealthy behaviors that they adopt, the obesogenic environment, and so forth. But it's also very much about societal conditions that exist in this country that differ from their home country, that are probably responsible for the deteriorating health outcomes. So it doesn't completely address your question. I don't think we have enough time to completely address your question, but I would just reiterate the theme that social conditions, living conditions, are just as important as the healthcare exposures that occur for immigrants in predicting their health outcomes, especially over multiple generations. I don't know if either of you want to add anything.
Sir?
What has your research found for people who go back to school? So people who drop out of high school and come back either to get their high school degree or a GED, or, I mean, it seems like a few years in college would you even help for people who come back later. Do you find any health effects or similar health effects there?
I haven't specifically looked at that. I don't know whether you have in your research.
We have, but we haven't published anything yet. The GED doesn't seem to help much. It's mostly because of they were high school dropouts in the first place. But the some college, yes, it does look like more advanced education later on in life definitely does have some health benefits. So, as I said, there are many, many ways in which education works. So one of the things to remember is that there are all these multiplier effects. There's so many channels by which education works that if you were to think about the kind of policy initiative, if we were to affect policy, how many ways would we really benefit the health? It would be a massive change.
It might be worth adding that as much as the theme of our comments is education matters a great deal, it would be wrong to not point out that we're still in our infancy in really understanding how this all fits together. Later on, in subsequent years, the researchers may look back and explain that education is sitting on a causal pathway, and that there are other environmental contextual conditions that are responsible for kids doing really well in school, or really succeeding in a profession. And the adverse factors responsible for their failure to succeed in school are also responsible for other bad things that happen to them that maybe lead to substance abuse or other problems. So we draw these causal connections now. We know that education matters a lot, but exactly how all these pieces interrelate with each other is still to be understood.
And encourage you to stick around for the reception and ask additional questions, but let's take one last question here from somebody, and then we'll go out and have some food and drink.
Does the education link also hold with mental health?
Well, I know that research that has looked at severe psychological distress, national surveys that have asked people about severe psychological distress, show a strong correlation there. So people with limited educational attainment are more likely to report higher levels of psychological distress. Again, it's hard to tease out sometimes the degree to which that represents something connected to education, or the fact that people who have less educational attainment are likely to be living under more difficult financial circumstances and experiencing other stresses related to that. But I'm not aware, and maybe others know, about evidence regarding mental illnesses such as depression, bipolar disorder, and so forth, whether there's an educational gradient for those.
Well, thank you all very much for attending this event, and thank you once again to all of our speakers. Please enjoy the reception.